नत्वहं कामये राज्यं न स्वर्गं न पुनर्भवं कामये दुःखतप्तानां प्राणिनाम् आर्तिनाशनम्. Meaning, I do not seek kingdom, heaven, or even rebirth. My only desire is to remove the suffering of those in pain. Thank you, ma'am. You can start the session.
Thank you, ma'am. Good evening, everyone. So today we are going to revise phase 2 pharmacology topic, antimicrobials, cancer, chemotherapy, and miscellaneous topics. Actually, I'm not going to give in a detailed lecture today. So I'm going to cover the previous year question paper topic wise, and then we will discuss the questions, how to present the questions, and if you have any doubts, I will clear your doubts. First, okay. So actually, in pharmacology, whatever question is asked, you have to write in this format. The main things you have to cover is, first you have to write what group of drug it is. If it is a short answer, you have to write what group of drug, and if it is a essay, you have to write the full classification. Then mechanism of action and pharmacological actions, then uses and adverse effects. These three, the underlined headings are a must headings. You have to write in these headings. And pharmacokinetics and the contraindications and drug interactions, if there is anything specific, you can write. Otherwise, no need to attend. Or we know that most of the drugs have better absorption in the empty stomach. You can highlight that point. Or some drugs are usually absorbed with a fatty meal. So if there is any specific characteristic feature of the drug, you can mention in the pharmacokinetic. And any contraindications. For example, metronidazole we should not give in alcoholic patients to prevent disulfiram-like reaction. So if for like that, if there is any specific contraindications and interactions, you have to write in the contraindications or drug interactions. Otherwise, these underlined headings are a must for in a pharmacology paper. So coming to first, so I have actually segregated the topics into four university questions, 1, 2, 3, and 4. In one, we are going to cover general antimicrobials, sulfonamides, quinolones, and beta-lactams. Actually, these are all the questions asked in the past 8 years. In the previous, these are all the questions asked from the previous question papers, university questions. So superinfection, post-antibiotic effect, and quinolones, they have asked many times. Very repeated question is quinolones, and anti-pseudomonal penicillins, cotrimoxazole, beta-lactamase inhibitors, and cephalosporins, mainly third generation cephalosporins they asked, and carbapenems. Coming to superinfection, so superinfection, actually we know that it is due to an appearance of a new infection as a result of antimicrobial therapy. And we know that normal microbial flora contributes to host defense by producing bacteriocins. This superinfection is commonly seen in immunocompromised patients. So the main antibiotics which causes superinfection are mainly broad spectrum antibiotics like tetracycline and chloramphenicol. In addition to that, aminoglycosides, ampicillin and clindamycin also causes superinfection. Main organisms involved in superinfection are mainly Clostridium difficile, Candida, Proteus, and Pseudomonas. The very common example for superinfection is pseudomembranous colitis due to Clostridium difficile. The drug of choice, actually it is a very important MCQ. So drug of choice for pseudomembranous colitis is due to Clostridium difficile is vancomycin. And alternatively, we can use metronidazole. So both the drugs we can use. But if they ask you drug of choice in an MCQ, it is vancomycin. So these are all the actually superinfection is an important short notes for you. So you have to write a definition and what are all the antibiotics causes superinfection, organism causing, and an example. And the next question is post-antibiotic effect. What is post-antibiotic effect? Normally, after exposure of an organism to the antibiotic, we know its growth stops. When it is placed in an antibiotic-free medium, the growth resumes, but only after a lag period. So this signifies that inhibitory effect is present even after when the concentration is below the MIC. What is MIC? Yes, any one of you can tell what is MIC?
Minimum inhibitory
Am I
concentration.
Yes, okay. So minimum inhibitory concentration. Even when the concentration is below the MIC, the effect persists. So that is called post-antibiotic effect. So if it is asked, you have to write the definition and the drugs which showed prolonged post-antibiotic effect. You can remember with the mnemonic FAR, F-A-R. F for fluoroquinolones, A for aminoglycosides, and R for rifampicin. So drugs, prolonged post-antibiotic effect can also be asked in MCQ also. So remember FAR, FAR is for fluoroquinolone, aminoglycosides and rifampicin. So actually I am going to share many mnemonics. Whichever is comfortable for you, you remember that. Otherwise, no issues, because if you keep mnemonics for everything also, it is very difficult to remember the mnemonic. So whichever is difficult for you, you can make a mnemonic. Otherwise, you use the mnemonic which I have now I am showing. Okay. So this is about post-antibiotic effect. Then we'll discuss broadly the mechanism of action of the antimicrobials. So the most common two mechanisms are, one is we know cell wall synthesis inhibitor and protein synthesis inhibitor. Actually, usually students, what they will do, if they don't know exact step, they will usually confuse which is protein synthesis, which is cell wall synthesis. Okay, so there is no way. You have to remember at least broadly. Even if you don't know the specific step which it inhibits, also no issues. At least write whether the drug is a cell wall synthesis inhibitor and whether it is a bactericidal or a bacteriostatic drug. Whenever the antimicrobial question is asked, you have to write these 2 points. So what is the mechanism and what is the effect, whether it is a bactericidal effect or bacteriostatic effect. So coming to cell wall synthesis inhibitors, the drugs which exhibits acts by cell wall synthesis inhibition are beta lactams. So beta lactams, many usually think, if they ask beta lactams, many think beta lactamase inhibitors. Beta lactamase inhibitors is different from beta lactams. Okay, so clearly see the question and start write the answer. So beta lactams are mainly penicillin, cephalosporin, monobactam, and carbapenems. Beta lactamase inhibitors are different. That we will discuss later. So these 4 acts by inhibiting cell wall synthesis inhibition. And phosphomycin, vancomycin, bezitracin, cycloserine. All these are cell wall synthesis inhibition. And each acts by inhibiting specific enzyme or specific step in the cell wall synthesis. Even if you don't know the specific step, at least write, if any of these drugs is asked, write it acts by cell wall synthesis inhibition. Coming to protein synthesis inhibitors, normally all the protein synthesis inhibitors are bacteriostatic. Mostly these beta lactams are bactericidal drugs. So in protein synthesis inhibitors, all are bacteriostatic except main drug aminoglycosides. Aminoglycoside is a bactericidal drug, but which acts by protein synthesis inhibition. All other are bacteriostatic. So the drugs which acts by inhibiting protein synthesis are aminoglycosides, tetracycline, and tigecycline, which comes under glycyl cycline, chloramphenicol, macrolide, lincosamide, streptogramins, and linazolide. All acts by causing protein synthesis inhibition. So coming to the each specific mechanism of action. So the first, many drugs acts by affecting even the cell membranes. The main drug is polymyxins. Then mainly by cell wall synthesis inhibition, that is beta lactams, vancomycin, and bezitracin. Next, drugs which acts by inhibiting the folic acid synthesis, mainly sulfonamides and trimethoprim. Both acts by inhibiting the synthesis of folic acid. Then comes this quinolones. Quinolones mainly acts by inhibiting the DNA gyrase enzyme. Then rifampicin mainly acts by inhibiting DNA-dependent RNA polymerase. And coming to protein synthesis inhibitors, we can divide into 30 years and 50 years. So 30 years mainly remember by the mnemonic AT. So A for aminoglycosides, T for tetracycline, both binds to 30 years and inhibits the protein synthesis. For 50 years subunit, remember LCMSC. Otherwise LCMSC, whichever is easier for you, remember. So L is for linazolid, clindamycin, macrolides. Macrolides mainly, can you name the macrolides? Yes? Can you name Any one of you, can you tell me the macrolide? Any one macrolide? Yes? Very good. Can you name any one aminoglycoside? Yes, ma'am. Aminoglycoside. Very good. Erythromycin, azithromycin, madam. Aminoglycosides?
Gentamicin, streptomycin.
Yes. Very good. Gentamicin. So don't confuse because both the groups ends with mycin. So mostly students confuse with these two, aminoglycosides and macrolides. So don't confuse. So mycin, MYCIN. So erythromycin, azithromycin and all, clarithromycin comes under macrolides. Gentamicin, streptomycin, okay, amikacin, kanamycin all comes under aminoglycosides. So this macrolides, clindamycin, chloramphenicol, streptogramins mainly binds with 50S and inhibits the protein synthesis. So coming to steps in the synthesis of, it is very difficult for you to remember the each step now. So just concentrate how this beta-lactams, penicillins, mainly the beta-lactam, the main is penicillin and cephalosporins. Penicillins mainly inhibit which step? The final step, that is by inhibiting the which enzyme? Transpeptidation. That is transpeptidase enzyme, thereby inhibiting the cross-linking of the elongated chain. So this is the step by which penicillin acts by inhibition of transpeptidase enzyme. So thereby it inhibits the cell wall synthesis. This transglycosylase is inhibited by vancomycin. So these two are very important. Remember these two. Penicillins act by inhibiting transpeptidase. Vancomycin acts by inhibiting transglycosylase. So this is the, I think we will share the PPT at the end. So you can refer this. Beta-lactam antibiotics mainly inhibit transpeptidase. Vancomycin mainly inhibit transglycosylase. So coming to protein synthesis inhibitor, I have told you 30 years, 50 years. So this is the first step. So this diagram, this image is given in the Tripathi. So kindly refer. So this first step is aminoglycoside. So aminoglycoside acts here. It binds to 30S, 50S interface and inhibits the misreading of the mRNA code. That is the first step inhibited by aminoglycosides. And this is the site of action of tetracyclines. Okay, tetracycline mainly inhibit the attachment of amino acid to the A site, amino acid tRNA to the A site. So this is inhibited by tetracycline. And this is peptide bond formation is inhibited by chloramphenicol, and this translocation of the peptide bond step is inhibited by macrolides. So these are the four main mechanisms of mechanism of action of the protein synthesis inhibitors. So I have made it as a table. So you can refer aminoglycosides, mainly 30 years, Siddle drug among the proteins. So this only Siddle drug acts by causing misreading of the mRNA code. And macrolides, clindamycin, quinipristin all inhibits translocation of the peptide bond. Okay, so that is by binding to 50 years. Tetracycline inhibits the attachment of amino acid to RNA to the A site. So 30 years static. Chloramphenicol interferes with the peptide bond formation. So binds to 50 years. Linezolid inhibits initiation by binding to 50 years. Even if you don't know which step, exact step, at least right, these drugs acts by inhibiting the protein synthesis. So coming to first drug, actually it is a common short answer. Usually they ask cotrimoxazole. We know cotrimoxazole is a combination of fixed dose combination of two drugs, sulfamethoxazole and trimethoprim. So always you have to write the ratio. So remember T for 1. Okay, so trimethoprim is in the ratio of 1 and sulfamethoxazole in a ratio of 20. 20:1 or 5:1 is the ratio. So of fixed dose combination. So sulfamethoxazole acts by inhibiting the folate synthase, trimethoprim by inhibiting the dihydrofolate reductase. So this is a combination FDC of cotrimoxazole. Don't confuse cotrimoxazole and clotrimazole. What is clotrimazole? Can anyone of you tell me what drug it is? Clotrimazole?
It's antifungal, triazole.
Very good. Clotrimazole. Okay. So because we know that many drugs ends with azole. Okay. So many usually students get confusion with this cotrimoxazole, clotrimazole, ketoconazole, everything. Ketoconazole, clotrimazole, and all antifungal drugs. Cotrimoxazole is a FDC of sulfamethoxazole and trimethoprim. So drug of choice, it is PNB, Punjab National, any national bank you were Punjab National Bank usually it's a mnemonic for the users. Pneumocystosis, nocardia, Burkholderia, UTI, respiratory tract infections, MRSA, all the respiratory and urinary tract infections we can use. And in addition to that, MRSA, methicillin resistant Staph aureus, and medullary and sinus infections we can use. So mnemonic, what are the adverse effects we can expect with cotrimoxazole? Mnemonic is ABC rash. See, ABC is nothing but for aplastic anemia, bilirubin displacement. It usually causes kernicterus. And C, crystalluria, rash or for rash, A for acetylation, and S for SLE, and H for hemolysis. Usually sulfonamides undergo metabolism by acetylation. That's why for A is for acetylation, and S for SLE, H for hemolysis in G6PD deficiency patients. So this is all the adverse effects mainly. This ABC is an adverse effect. A alone is just a pharmacokinetic feature. It undergoes metabolism by acetylation. Other things are adverse effects. So remember the mnemonic ABC rash for cotrimoxazole, and FDC ratio. Remember T. So T for 1 and 1. So usually this ratio, usually students get confused with the ratio. So 20:1. Trimethoprim remembers the first letter T for 1 and it is a 1 ratio, and sulfamethoxazole 20 or 5. So that's all about cotrimoxazole. So remember what drug it is, you have to write mechanism of action, you have to write the folate synthase and dihydrofolate reductase, and uses you have to write this and the adverse effects. So coming to the questions, previous year main essay asked, actually this type of question asked twice in the previous 5 years itself. They have asked this question twice, this fluoroquinolones. So actually the question is a 15-year-old girl admitted with a fever, headache and stomach pain. She revealed that she had visited Marina Beach last weekend and ate from the roadside food stall. So what could be the diagnosis, available drugs to treat this condition, and the mechanism of action in detail about ciprofloxacin. So what is the diagnosis? We know. So history of outside food intake is there, and along with fever, stomach pain and headache. So probable diagnosis is typhoid fever. Okay, so you have to write what are all the drugs available to treat this condition and in detail about ciprofloxacin. First we will see and the next question, and the next year also they have asked a similar question. So 25-year-old man, continuous low-grade fever 7 days, and the blood culture report was positive for S typhi. So they have directly given the diagnosis. Sometimes they have given directly the diagnosis also. Sometimes they will give only the clue. Okay, you have to identify. So here for both the question, what is the diagnosis? Typhoid fever. So what are all the drugs? Here you can see they have broadly asked what are all the drugs we can use to treat this condition, and here they have specifically mentioned empirically used. So empirically used means without proper blood culture report itself you can start with the drug. Okay, so empirically used in this condition is if you, even without the report, if you suspect a typhoid fever, you can start the drug. That is called empirically used drug. And you have to remember so you have to write the mechanism, adverse effect and uses. And in addition to that, they asked fluoroquinolones also. So with this, you can come to the conclusion that this drug is different from quinolones. Okay, so quinolones they have asked separately. So this drug must be what drug? Any idea? Empirically used in typhoid fever other than fluoroquinolones. What is the answer for this? B. Esma, any idea? Which is the drug empirically used in typhoid fever other than fluoroquinolones? Yes, give a try.
Ceftriaxone.
Yes, very good. Cephalosporins. Okay, cephalosporin, mainly third generation cephalosporins are empirically used because fluoroquines many are resistant. So nowadays empirically used drug is cephalosporins, then fluoroquinolones. So coming to discussion of fluoroquinolones. So fluoroquinolones mainly, fluoroquinolone, the main mechanism of action is it acts by inhibiting the replication by preventing uncoiling. By inhibiting which enzyme? DNA gyrase enzyme. Okay, so the mechanism of action is DNA gyrase inhibition, thereby inhibits the replication. So the main important characteristic features of fluoroquinolones are it has wide spectrum action, and whenever you fluoroquinolone is asked, you have to write it is contraindicated in pregnancy and children less than 18 years because of the risk of cartilage damage and tendinitis or tendon rupture. So fluoroquinolones means you should write compulsory this cartilage damage and tendon rupture. They will expect this. And it may induce seizures, and it is contraindicated in renal failure. And coming to specific characteristic features for each drug, ciprofloxacin commonly used in chemoprophylaxis of meningococcal meningitis. Norfloxacin is used in UTI, and there are drugs called respiratory fluoroquinolones, mainly this. Oh my God, you can remember as OMG, ofloxacin, moxifloxacin, gatifloxacin, and levofloxacin. OMGL, Oflox, Moxiflox, Gatiflox, and Flevoflox. They are called respiratory fluoroquinolones. So we know that fluoroquinolones, from this itself, you can write the uses. So we can use in UTI, we can use in meningococcal meningitis, and we can use in respiratory infections, and in addition, typhoid we can use, and Pseudomonas. So then in bracket, I have mentioned that drugs commonly used in Pseudomonal infection, Cipro and Levo. And TB, mainly these fluoroquinolones are second line drugs, Cipro, Levo, and moxifloxacin are used in TB, anthrax, bone and joint infections, and respiratory infections, I have already told you. And the main another toxicity seen with fluoroquinolones is phototoxicity. It is maximum with spar. These are all MCQ point of view, it is important. So maximum phototoxicity is exhibited by sparfloxacin. So these are all the main points for fluoroquinolones. Acts by inhibiting DNA gyrase. And remember these common uses and adverse effects. Adverse effect, remember tendinitis and tendon rupture, and it is contraindicated in pregnancy and also renal failure. So what are all the drugs used in typhoid? So empirically used is ceftriaxone, macrolides we can use, fluoroquinolones already we have discussed, and in addition to that, alternative drugs are chloramphenicol, ampicillin, or cotrimoxazole. These are we are using rarely. So main drugs are cephalosporins and fluoroquinolones. Alternative azithromycin can be used. So coming to cephalosporins, we know cephalosporin classification anyhow you have to remember, make your own mnemonic and remember the drug names. So just I have put this, whether if you want you can use this mnemonic, otherwise make your own mnemonic. So first generation usually contains the far pronunciation, cefazolin, cefalexin, okay, far. And the second generation mainly cefuroxime, cefaclor, cefoxitin, mainly many drugs contains cefoxitin, cefotugen. And third generation is ceftriaxone, cefatoxime, ceftazidime. And fourth generation only main drugs are cefepime and cefpirone. So it contains PI. And fifth generation is ROL. It contains ceftaroline, ceftabiprole. Okay. So favorite food teach family fifth time, but it's difficult. You can make your own mnemonic and remember the drug names. Third generation is very important. And coming to spectrum of these generations, first generation normally it is active against gram-positive, and third generation has wider spectrum. Fifth generation mainly active against MRSA. And mechanism of action, we know it also acts by inhibiting the cell wall synthesis, and it is bactericidal. Always write for antimicrobials whether it is a bactericidal or bacteriostatic, then start the mechanism of action. Okay, so cell wall synthesis inhibition, bactericidal drug. So coming to the main individual characteristic feature. So main drug which causes this secreted in bile. Okay, so this is called the ceftriaxone is the main drug. And coming to anti-pseudomonal penicillins, drugs which are mainly active against pseudomonal infections are cefepime, cefpirone, cefoperazone, ceftazidime. So these are mainly active against pseudomonas. And drugs which are active against disulfiram-like reactions, which causes disulfiram-like reactions are cefoperazone. Actually, these are all MCQ point of view. It is very important. Okay, cefoperazone, moxalactam, and cefotetan and cefoxitin. So drugs which cephalosporins which causes disulfiram-like reaction. And coming to overall uses, ceftriaxone is the drug of choice in gonorrhea. And in typhoid fever, third generation cephalosporins are used. The advantage over other available drugs, this you have to write if they ask you in essay or short notes. The ceftriaxone, why this third generation cephalosporins are empirically used. It produces quick defervescence. It causes early abatement of symptoms, low risk of relapse and complications, and prevention of carrier state. So these four are the main advantage of third generation cephalosporins. In meningitis, we can use cefatoxim, ceftriaxone, third generation. Surgical prophylaxis, we use cefazolin. And septicemias, we can use cephalosporins. Alternative to penicillins in ENT infections and upper respiratory tract infections, and respiratory, urinary and soft tissue infections, many drugs are third generation drugs are used. So overall, mainly individual uses we can write as an overall uses also. So this is the mnemonic. And coming to the next question. So patient presents with the fever with rigor and burning sensation. Okay. So mainly this patient has fever, rigor and burning sensation while passing urine for the past 3 days. What is the diagnosis? And mention safe antimicrobial agents in pregnancy. And describe the mechanism of action uses. Actually, usually they give a clue. Whenever you see this type of case scenarios for UG level, you can get a clue. So what is the diagnosis? Safe antimicrobial agents, and they have asked penicillin. So from this, you know, penicillin is the safer antimicrobial agent in pregnancy. So that is the clue here. And suicide inhibitors. Any idea what is suicide inhibitors? Yes? Have you heard this term suicide inhibitors, ma? Any idea? Actually, this is I think, before 3 years, I think they have asked the 20 batch, I think. What is suicide inhibitor? Yes? Can any one of you tell me what is suicide inhibitor, ma? Yes? Am I audible? Am I audible?
Yes.
Okay, what is suicide inhibitor? Okay, this beta lactamase inhibitor is called suicide inhibitor. Mainly clavulanic acid only we usually tell a suicide inhibitor. Okay, so beta lactamase inhibitor. Clavulanic acid is a suicide inhibitor. So if they ask you suicide inhibitor, write the beta lactamase inhibitors. Okay. So safer drugs are mainly penicillin. So this is UTI in pregnancy. That is the diagnosis. So what are all the drugs safe? Beta lactams, mainly penicillin, cephalosporins, and nitrofurantoin. But we have to avoid near term. You have to avoid. There is a more chance of hemolytic anemia in neonates. And phosphomycin we can use, which is also a cell wall synthesis inhibitor, and azithromycin. So these are all the drugs used in safely in pregnancy, UTI. So coming to penicillins, so we know that what is the natural penicillin, which is a penicillin G. What are all the drawbacks of penicillin G? Why there are many semisynthetic penicillins available? Because it is not effective orally, because directly even penicillin G they are asking in essay. So as a short note also they have asked. So you should concentrate, you should know why, what are the drawbacks of penicillin G. So it is not effective orally because it is acid labile, shorter acting, narrow spectrum, and resistance due to beta lactamase or penicillin binding proteins, and hypersensitivity reactions are commonly seen with penicillin G. So there are many semisynthetic penicillins available, synthetic and semisynthetic penicillins available to overcome these adverse effects. Since it is short acting, to make penicillin G longer acting, we are attaching two groups called benzathine and procaine. So benzathine and procaine penicillins are longer acting penicillins. And to overcome the acid labile nature, so we have drugs are acid resistant penicillins. You can remember as VODCA, vodka. Okay. So penicillin B, oxacillin, dicloxacillin, cloxacillin, and A for ampicillin or amoxicillin. And extended spectrum, since penicillin G is a narrow spectrum, we can use extended spectrum penicillin called ACT-MAP. So you can, this is very important, this extended spectrum. You can remember with the mnemonic ACT-MAP. ACT is nothing but A for ampicillin or amoxicillin, C for carbenicillin, T for ticarcillin. Okay, ACT. And MAP. MAP is for meslocillin, aslocillin, piperacillin. We usually tell the CT MAP. The CT MAP is together called anti-pseudomonal penicillin, which is an important short notes for you. And if they ask you anti-pseudomonal penicillins, you have to write the CT MAP. CT is for carboxypenicillin, carbenicillin and ticarcillin. They are called carboxypenicillin. And MAP is for mesclocillin, aceclocillin and piperacillin. Together they are called uridopenicillin. So carboxy and urido together called anti-pseudomonal penicillin, which are active against Pseudomonas. And this MAP is useful in Klebsiella infection also. And coming to penicillinase resistant penicillins, that is the penicillins which are resistant to this, because these things you have to memorize, because in MCQs also they may ask you. So among these, which of the following is an penicillinase resistant penicillin, or they may ask you as acid resistant penicillins. Okay, so you have to remember this. So remember for CM DON. Okay, C for cloxacillin, methicillin, DON for dicloxacillin, oxacillin and nafcillin. So this is for penicillinase resistant penicillins. So mainly this methicillin, you have to remember it causes interstitial nephritis and hematuria as an adverse effect. And nafcillin, it causes, remember N for N, neutropenia. Okay, so these are the main points to remember for penicillins. And coming to main mechanism of action, I have told you bactericidal effect inhibits inhibition of transpeptidase enzyme and causes inhibition of cross-linking of the peptidoglycan. So undergoes causes cell wall deficient bacteria which undergoes lysis. So bactericidal effect. And coming to uses of penicillins, you can remember with lost man. Lost man is the mnemonic for uses of penicillins. L for listeria, actinomycosis, syphilis, and T for tetanus, M for meningococcus, and An for anthrax. So for syphilis, drug of choice is benzathine penicillin. So indications, remember with lost man. And coming to adverse effects, you have to remember hypersensitivity reaction and Jarris eczema, which is nothing but if you use penicillin in a syphilitic patient, there will be an initial acute reaction occurs, which causes fever, chills, reaction that is called Jarris eczema reaction. So remember these two main adverse effects for penicillin and lost man for users. And beta-lactamase inhibitors. What are beta-lactamase? I have told you beta-lactamase is an enzyme which breaks the beta-lactam ring of penicillin and causes resistance. Okay. So this beta-lactamase inhibitors, if we use along with penicillin group drugs, they prevent the resistance. So if they ask you in short notes, first you have to write the definition. What is the role of beta-lactamase? So beta-lactamase break the structure of penicillins. So break the beta-lactam ring and causes resistance. So this beta-lactamase inhibitors inhibit the beta-lactamase and prevent the resistance. So what are all the beta-lactamase inhibitors? Clavulanic acid, sulbactam and tazobactam. Clavulanic acid is called suicide inhibitor because it binds to the drug and immediately it itself degrades. So after the action, it degrades itself. That's why it is called suicide inhibitor. And it usually combines with amoxicillin, zolbactam with ampicillin, and tazobactam with piperacillin. I have made a table also in the next upcoming slide, and you can refer the slides for beta-lactamase inhibitor short notes. So coming to main drug interaction for penicillin. So with probenecid, we know what is probenecid. What drug it is? Yes. Try to remember so that you can.
It's a uricosuric drug.
Yes. Probenecid, what drug it is, ma?
It's a uricosuric.
Yes. Is it gout? It is used in gout. So probenecid. So mainly this drug actually along with actually penicillin and probenecid both actually uses organic acid transporter for their transport. Okay. So if you use penicillin along with probenecid, what will happen? Probenecid causes the transport of penicillin and inhibit the excretion of penicillin and prolongs the duration of action of penicillin. So probenecid penicillin drug interaction is very important. So whenever we use probenecid and penicillin together, duration of action of penicillin is prolonged because of the competitive action of probenecid with the same transporter. Okay, so this is the main drug interaction you have to remember for penicillin. And this is the the table I have made for anti-pseudomonal penicillin. Already I have discussed CT map, carboxypenicillin and uridopenicillin, and you can refer this table for short notes of anti-pseudomonal penicillins. And also for beta-lactamase inhibitors, remember CAST, C-A-S-T, CAST. So C for clavulanic acid, A for this avibactam, S for sulbactam, T for tazobactam. And which drug combined with which penicillin beta-lactams, you have to know. Clavulanic acid with amoxicillin, sulbactam with ampicillin, tazobactam with piperacillin, and avibactam with ceftazidime. Okay, and this refer this table for beta-lactamase inhibitor short notes. And so that's all about the first part of university questions in antimicrobials. So far I have discussed what is superinfection and post-antibiotic effect. So they are most commonly asked short notes, and cotrimoxazole, fluoroquinolones, repeated questions, and in detail about beta-lactams, penicillins and cephalosporins. In that, anti-pseudomonal penicillins and beta-lactamase inhibitors and third generation cephalosporins are commonly asked. Okay, so any doubts, ma? So far, any doubts in this first part? So many of you have answered in the chat box. Normally I'm seeing. Very good. So any questions for doubts, ma, in the first part till beta lactams? Shall we move on to second part? Okay. Okay. Okay, coming to second part, mainly concentrated on broad spectrum I have put that in second part, mainly this broad spectrum antibiotics, aminoglycosides, vancomycin, and other miscellaneous antibiotics, macrolides also. So the main repeated questions are mainly this vancomycin. Many times they have asked tigecycline, twice they have asked linezolid, and aminoglycosides. They have asked in essay also, and short notes also aminoglycosides, and azithromycin macrolide. And this mipirocin, daptomycin, and all miscellaneous antibiotics. So we will discuss the main questions. Coming to first drug, vancomycin, I have already told you vancomycin mainly acts by inhibiting cell walls. That's why I have told you the table. You have to broadly at least read cell walls in the even if you don't know which step it inhibits, it acts by inhibiting the transglycosylase enzyme. But even if you don't know that, at least write cell wall synthesis inhibitor. Okay, and bactericidal drug, cell wall synthesis inhibitor, and narrow spectrum. Mainly, it is a reserved drug for all the resistant cases. Mainly methicillin resistant Staph aureus. This is the drug of choice. For vancomycin resistant Staph aureus, what is the drug of choice? Daptomycin. These are all MCQs. So MRSA drug of choice is vancomycin. For vancomycin resistant case, drug of choice is daptomycin. And other uses for vancomycin is corynebacterium infections and serious infections in penicillin allergic patients. And one more important point to remember for vancomycin is red man syndrome. So all of you, it is listen that it is very difficult to remember all the adverse effects. Even if you read and memorize, it is difficult to remember the adverse effects for all the drugs. Okay, so we know that most of the drugs causes GI disturbances. Okay, so in addition to that, you can write the specific characteristic adverse effect for each drug. For example, I have told you penicillin, hypersensitivity, Jarvis-Eczema reaction. Okay, and methicillin, I have told you interstitial nephritis. Nafcillin causes neutropenia, NN. So like that specific adverse effect you remember. Okay, so like that for vancomycin normally causes histamine release, so it causes very reddish rashes. So the syndrome called red man syndrome. So this is asked in MCQ also, which drug causes red man syndrome. So vancomycin is the answer. And for in short notes also, you have to write mechanism of action, spectrum, uses, and adverse effect red man syndrome for vancomycin. So this is the question asked previously, same UTI patient, and they have asked what is the diagnosis and enumerate the classes of. In the previous question for penicillin, I have shared on question or university question. In that they have asked only the drugs used pregnancy in UTI. Here they have asked enumerate the classes of antibiotics useful in treating the above patient, and write in detail about aminoglycosides. And again they have asked UTI in pregnancy. Already UTI in pregnancy I have discussed. So what are all the drugs we can use in antibiotics we can use in the UTI? So beta lactams we can use, fluoroquinolones, nitrofurantoin, even cotrimoxazole, and phosphomycin and aminoglycosides for complicated urinary tract infections. So these are all the drugs. If they ask you drugs used in UTI, you have to write all these, even cephalosporins, beta lactams, so cephalosporin and penicillins you have to write. So coming to aminoglycosides. So it is a very important question, aminoglycosides. Even short notes also they have asked, and essay also many times they have asked. So mainly these drugs, main point is it is the only bactericidal drug among protein synthesis inhibitors. Okay, it binds to 30S 50S interface and inhibits the protein synthesis and causing misreading of the mRNA. The initiation step itself it inhibits, and it is inactive against anaerobes because it requires O2 for its entry, transport into the bacteria. It requires oxygen. So it is inactive against anaerobes and exhibit CDK. What is CDK? Concentration dependent killing. And already I have told you one mnemonic FAR for prolonged post-antibiotic effect. So in FAR for A is for aminoglycosides. And concentration, we know that two type of killing exhibited by antimicrobials, mainly concentration dependent killing and time dependent killing. So concentration dependent killing is exhibited by aminoglycosides. So it is not effective orally, mainly active on gram negative organisms. Okay, so remember, so far we have seen many drugs are active against gram positive initially, and only in generations, higher generations only they are active against gram negative. Here aminoglycosides is active mainly on gram negative infections, and uses, we know gram negative, all the gram negative infections, respiratory urinary tract infections, we can use gentamicin, tobramycin, amikacin. Streptomycin, nowadays it is removed from the first line drug in TB, but still we can use as a reserve drug TB, plague and tularemia, but the adverse effect is mainly ototoxicity. Amikacin, we can as a second line drug for, it is used in multi-drug resistant tuberculosis, and it is a second line drug in TB. And neomycin topically, because it has more systemic toxicity, so it is reserved for only for topical use. And spectinomycin in PPNG is nothing but penicillinase producing Neisseria gonorrhea. Okay, so these are all the uses of aminoglycosides. Adverse effect, I think you know, because adverse effects for aminoglycosides is very important. 3 toxicity. One is ototoxicity, nephrotoxicity, and neuromuscular blockade. Okay, so remember the adverse effect for aminoglycosides is very, very important. Ototoxicity maximum seen with amikacin, and it is also seen with streptomycin. Nephrotoxicity maximum seen with neomycin, and neuromuscular blockade also maximum seen with neomycin. Remember N for N. Nephrotoxicity also neomycin is the most commonly caused drug among the aminoglycosides, and neuromuscular blockade also NN, neomycin. Okay, ototoxicity maximum seen with amikacin. So remember the adverse effect. So aminoglycosides bactericidal, inactive against anaerobes because it requires O2 for its transport into the bacteria, mainly active against gram negative infections, and adverse effect is ototoxicity, nephrotoxicity, and neuromuscular blockade. So coming to next, macrolides. Macrolides, azithromycin, erythromycin are macrolides. So mainly it inhibits protein synthesis by binding to this 50S ribosomes. Then mechanism of action, I know I have already told you, it blocks the final step, that is translocation of peptide chain from A to P site. Even if you don't remember this, right, it binds to 50S and inhibits the protein synthesis. And the main drugs are acithro, clarithrose, pyramycin. Acithro, we know it is mainly commonly indicated in chlamydia infection and gonorrhea, and alternatively to ceftriaxone. Okay, so third generation cephalosporin, ceftriaxone is indicated in these conditions. In addition to that, there's an alternative first line of drug for gonorrhea and chlamydia. Clarithromycin, MAC infection, that is Mycobacterium avium complex. Pyramycin for toxoplasmosis. And remember the uses, other uses as CLAW, CLAW. CLAW is the mnemonic for macrolide use. C for cancroid, L for legionella, A for atypical pneumonia, and W for whooping cough. CLAW is the mnemonic for uses of macrolides. In addition to this, and coming to adverse effect, you can remember as macro. Macrolides, adverse effect mnemonic is macro. So M for, it is an agonist of, so motilin receptor. M, remember M for motilin receptor. So what happens if erythromycin is given? It acts as an agonist for motilin receptor and causes diarrhea as an adverse effect. So remember, motilin causes diarrhea. And A for allergy, C for cholestasis, R and O for reversible ototoxicity. R and O same, reversible ototoxicity. Sorry. So macro is the mnemonic for ADR of macrolides. And mainly this erythromycin macrolides, erythromycin is an inhibitor of CYP3A4. So remember this. So these are all the main characteristic points for macrolides. So protein synthesis inhibition, remember CLA and macro and inhibitor of CYP3A4. Coming to other individual drugs asked many times, tigecycline actually they have asked. Tigecycline mechanism is same as tetracycline. It is a glycyl cycline, broad spectrum action. So broad spectrum means in all resistant cases, MRSA, VRSA, anaerobes and other drugs. Only it is used IV, excreted in bile and serious complicated infections, skin and abdominal infections we can use. So right for mechanism of action, same as tetracyclines. Okay, binds to 30S ribosome and inhibit the protein synthesis. Clindamycin, mechanism of action, same as macrolides, bind to 50S and inhibits the final step translocation. Uses, remember, as CAP. Clindamycin uses, remember, CAP is the mnemonic, gram-positive cocci, anaerobes, and P for parasites. Mainly this pneumocystis carinii pneumonia, malaria, and toxoplasma it is used. P is nothing but pneumocystis carinii pneumonia. Next is linezolid. Linezolid also protein synthesis inhibitor. The main point for linezolid is all the resistant cases, MRSA, VRSA, and vancomycin resistant enterococcus. All these infections it is used. Adverse effect is thrombocytopenia and neutropenia. Remember, thrombocytopenia is the major dose limiting side effect of linezolid. And MAO, it has MAO inhibitory action, causes serotonin syndrome. Okay, so these are all the main uses of linezolid, and these are the main questions. Many times in short notes they have asked these questions: tigecycline, clindamycin, and linezolid. So that's all about part 2. So in part 2, main questions are aminoglycosides, vancomycin, and this other drugs, tigecycline, linezolid, and clindamycin they have asked, and macrolides. Okay, so that's all about question part 2. Okay, any doubt in part 2, ma? Yes. As actually, if you read once again, if you use this PPT and read, it will be useful for you. So because if you ask, it's difficult to remember the mnemonics. So repeatedly, if you see, you can read. Okay, so you can remember. So any doubts in second part, ma? Yes. Am I audible? Yes. No doubts. Many of you written no, ma'am. No, ma'am means am I not audible? Or no doubts? Okay. Am I audible? Can any one of you tell me, am I audible, ma? Yes.
Yes, ma'am.
Okay. So coming to the very important topics, most expected essay topics: anti-malarial, anti-tubercular, fungal, viral, and amoeba. So please listen. These are the very important essays, repeated essays they have asked, and nowadays they are asking this multi-drug resistant tuberculosis and extensive drug resistant. Actually, they are not at all asking first-line drugs. Directly, they are asking multi-drug resistance and extensively drug resistant regimens. I have made a easy mnemonics for that. So please listen. And anti-malarial drugs very important, and viral short notes they have asked many times, and anti-amoeba and helminth short notes are expected. And even amoeba once they have asked in essay also, metronidazole. Okay, so these topics I have included in the part 3. We will discuss quickly. So anti-malarial drugs, many times they've asked chloroquine and artemisinin based combination therapy and prophylaxis of malaria. So coming to, before going into the topic, you should know there are 3 phases we know. Okay, so pre-erythrocytic stage, erythrocytic stage, and gametocidal. Okay, and exoerythrocytic, and drugs which acts by inhibiting the killing the gametes. Okay, so pre-erythrocytic, erythrocytic, and exoerythrocytic stages are there. And prophylaxis of malaria is normally asked once in a short notes and once along with the essay as a part of ABC questions, and one as a part of essay it is asked. So coming to prophylaxis, causal prophylaxis is mainly drugs which acts at pre-erythrocytic level are called causal drugs used for causal prophylaxis. Radical cure means drugs which acts at the exoerythrocytic stage, and this drugs which prevent this transmission is mainly drugs which produces gametocidal effect, And drugs which causes clinical cures or suppressive prophylaxis. Okay, so if they ask you in prophylaxis, you should write causal prophylaxis, suppressive prophylaxis, radical cure, and drugs which prevent transmission. So coming to drugs for causal prophylaxis, remember 3P. 3P is the mnemonic for drugs used in causal prophylaxis: proguanil, primaquine, and pyrimethamine. 3Ps: proguanil, primaquine, and pyrimethamine. So for causal prophylaxis. Suppressive prophylaxis is nothing but drugs used in the treatment. So nowadays we are commonly using artemisinin derivatives over chloroquine. So drugs used in the treatment part is called suppressive prophylaxis, mainly artemisinin, chloroquine, and mefloquine. Drugs used for radical cure, that is mainly acts on the exoerythrocytic stages, primaquine. So primaquine is used in radical cure, that is acts on the exoerythrocytic stage. And drugs which acts for gametocidal action is 3Ps. Already I have told you what are 3Ps, plus artemisinin is useful in gametes, okay, in killing the gametes. So these are all the drugs used in the prophylaxis. So remember, causal prophylaxis, suppressive prophylaxis, radical cure, and gamete drugs which has gametocidal action. So I have discussed, I have made a PPT specifically for the slides for chloroquine and artemisinin and primaquine once they asked in short notes. So these three drugs we will discuss, and artemisinin based combination therapy. So coming to chloroquine, mechanism of action is simple. It is mainly due to accumulation of heme in the parasite. So accumulation of heme, which is very toxic to the parasite. So it will, so remember, at least chloroquine means accumulation of heme and which is toxic to the parasite. Okay. So mnemonic for other uses. Chloroquine, it is not only used in malaria. The other uses of chloroquine is very important. Remember as red lip MG. Red lip MG. So what is red? R for rheumatoid arthritis, E for extraintestinal amoebiasis, D for discoid lupus erythematosus, L for lepra reaction, I for infectious mononucleosis, and P for lip, L for lepra, I for infectious mononucleosis, P for photogenic reactions, and MG is malaria and giardiasis. So these are the mnemonic for other uses of chloroquine. And remember, it is safe in pregnancy. Chloroquine is safe in pregnancy. And regarding adverse effect, in addition to rashes, everything, remember, main adverse effect is retinal damage, blindness due to retinal damage, and it causes, it precipitate porphyria and discoloration of nails and mucous membrane. Remember, retinal damage, main adverse effect for chloroquine. For UG level, they won't expect you to write every adverse effect. Okay, if you highlight the characteristic adverse effect, it is that is enough for UG level. Okay, so remember, retinal damage for chloroquine, and it has large volume of distribution. It is an additional point for chloroquine, and it is safe in pregnancy. And coming to next drug, artemisinin derivatives, we know artesunate, arteether, and artemether are the main drugs. Mechanism of action is it acts by generating the highly active free radicals. So it produces damages the parasite membrane. So highly active free radicals are produced by the drugs and which damages the parasite membrane. The main disadvantage is shorter half-life. That's why we are commonly using artemisinin in the combination therapy along with the longer acting drug. Okay. So this artemisinin based combination therapy itself asked it's in a short notes. So what is this artemisinin based combination therapy? Why it is needed? Because artemisinin is a fastest acting and it has very short half-life. We usually combine any artemisinin derivative with a longer acting drug. Okay, that is called artemisinin based combination therapy. What are all the advantages? It causes rapid clinical and parasitological cure, higher cure rates and low recrudescence rate, absence of parasite resistance, and good tolerability profile. These four are the main advantages of ACT, that is artemisinin based combination therapy. Okay, so what are all the combinations commonly used? Is I have highlighted. No, this is the commonly used in India: artesunate plus sulfadoxine pyrimethamine. Okay, so artesunate 200 milligram OD for 3 days, and sulfadoxine pyrimethamine 1500 milligram plus 75 milligram on day 1. So this is the common combination used in our country. And other combinations are artemether, lumefantrine. Lumefantrine may cause QT prolongation, and artesunate mefloquine, dihydroartemisinin piperaquine, artesunate amodiaquine. Actually, in book it is detailed, they explain in detail, so it is very difficult to remember everything. At least remember what are all the combinations available, and in India which is the commonest combination useful, and what are all the advantages. Okay, this is enough for a short notes, and you have to write in addition to that mechanism of action of artemisinin derivatives. So coming to next trick, Promaquine. So it acts by forming redox compounds that acts as cellular antioxidants. So mainly it has no action on the erythrocytic stage, but we can use in pre. That is, I have told you, it is useful in causal prophylaxis. Among the 3 P's, Promaquine is the one P. Okay, so it is useful in pre, that is pre-erythrocytic stage, and also both in radical cure and also in causal prophylaxis. And it is used in gametocidal also. And no effect on erythrocytic phase. So it is contraindicated in pregnancy because it causes chemolysis. In what is the main adverse effect seen with Promaquine? It is very important. Even in MCQs, they usually ask. So drug which causes chemolysis in G6PD deficient patient is Promaquine. And other important points for other drugs are mefloquine. It may cause neuropsychiatric side effects. Lumefantrine, I have told you, QT prolongation. And remember, absorption with fatty meal is good. And quinine, it is also like chloroquine, safe in pregnancy, and main adverse effect for quinine is synchronism. Mainly it causes tinnitus. Okay, that is called synchronism. So these are all the other important points for the other drugs. Mefloquine, neuropsychiatric, lumefantrine, absorption with fatty milk, quinine, safe in pregnancy, and synchronism. Remember synchronism for quinine. This is also an important MCQ. Synchronism adverse effect seen with quinine. Okay, so that's all about anti-malarial drugs. So chloroquine, Promaquine, and artemisinin based combination therapy and prophylaxis. If you read this prophylaxis, you can write the treatment part also. So coming to very, very important topic, anti-tubercular drugs. So see here, so these are all the previous year question papers only I have taken. This multi-drug resistant XDR TB is asked many times, and MDR TB also asked even in essay also. Okay. So coming to chemoprophylaxis of the tuberculosis also asked. So tuberculosis, we know all the first line drugs, I think you know. Now, before it was 5, but now they have reduced, they have removed the S, only isoniazid, rifampicin, ethambutol, and pyrazinamide. Coming to mechanism of action, isoniazid and ethambutol inhibits the cell wall synthesis. Isoniazid mainly by inhibiting mycolic acid, ethambutol mainly by inhibiting the synthesis of arabinogalactan. Okay, so by inhibiting the arabinosyl transferase enzyme. Coming to rifampicin, mainly it acts by inhibiting the DNA-dependent RNA polymerase, so thereby inhibiting the RNA synthesis. Coming to pyrazinamide, mainly actually exact mechanism is not known, but it also inhibits somehow cell wall synthesis by binding to a different ATP synthase enzyme. Okay, so these are all the main mechanism of action. I have made a table for the main points for the first line drugs. All are CIDAL except one drug, which is static, is ethambutol. Remember this. And mainly this isoniazid and ethambutol are active against fast multiplying bacilli. Rifampicin for spurters, that is slow and intermittent going bacilli, and pyrazinamide for slow growing bacilli. And you have to remember this point, whether it is active against extracellular or intracellular. All the drugs are active against extra and intracellular except pyrazinamide, which is active against only intracellular. And the older drug streptomycin is active only against extracellular. Okay, they may ask you in MCQ. Only intracellular, only extracellular. And mechanism of action, I have told you, mycolic acid by isoniazid, DNA-dependent RNA polymerase inhibition by rifampicin, same mycolic acid, but binding to a different fatty acid synthase enzyme by pyrazinamide, and inhibition of arabinosyl transferase by ethambutol. And resistant genes, you have to remember for TB, CATG and INK gene for isoniazid, RPO-B gene mutation for rifampicin, TNC-A gene for pyrazinamide, and EMB-B gene for ethambutol. So these are this table, refer the main points. And coming to main pharmacokinetic points, isoniazid, you have to remember it is metabolized by acetylation. So based on that only, we know that slow acetylators and fast acetylators. We Indians are mainly slow acetylators. So slow acetylators and fast acetylators. So remember, you can write this in pharmacogenomics also. Okay. And mnemonic for drugs which undergo metabolism by acetylation is SHIP. It is a very important MCQ. They may ask you this. What are all the drugs which undergo metabolism by acetylation? SHIP drugs. S for sulfonamide, H for hydrolysine, I for isoniazid, and P for procainamide. Okay. And rifampicin, you actually twice they have asked why we should not combine this rifampicin along with ATT drugs along with contraceptives. What is? Because rifampicin included in the first line drug is an enzyme. We know it is an enzyme inducer of CYP450. So if you give along with oral contraceptive pills, there may be a contraceptive failure. Okay, so this clinical question is asked as a part of a essay question. It is asked, and this is the important points for isoniazid and rifampicin. Pharmacokinetics is important. And uses, there are other uses for ethambutol. In addition to TB, we can use in a Mycobacterium avium complex, and also rifampicin. There are many other uses. TB, leprosy. In addition to that, prophylactically we can use for meningitis, and second or third choice drugs for MRSA, diphtheria, Legionella infection, and also brucellosis. These are other uses of rifampicin. Once they have asked only rifampicin in essay, they classify the first line drugs in detail about rifampicin itself. They have asked, so you should know the other uses for rifampicin. Okay. And coming to ADR, hepatitis and hepatotoxicity is seen with isoniazid, rifampicin, and pyrazinamide. All the drugs causes hepatitis except ethambutol. And peripheral neuritis seen in slow astellators for isoniazid. So to prevent this peripheral neuritis, we usually give pyridoxine prophylactically in patients with isoniazid. Okay. And also orange red secretion for rifampicin and flu-like syndrome. And pyrazinamide, hyperuricemia, gout is commonly seen. Ethambutol, optic neuritis. Okay, color blindness. So optic neuritis is seen with ethambutol. So these are all the main adverse effects seen with first line drugs. Regimen, this is very important. All of you listen. TB regimen is very important. So first line TB, what is the regimen? We know for drug sensitive TB, we know 6 months. Actually, before the classification was very extensive, now they made it easily. Even the National Tuberculosis Elimination Program of our country itself made it very easy that 6 months regimen, 2 HRST plus 4 HRE. This is a very commonly used and for this drug sensitive TB. And in case of extrapulmonary TB, 2 HRST, same for intensive phase, but continuous phase we can extend up to 6 months. Okay, so that is the difference. 2 HRST, 4 HRE for drug sensitive TB. For extrapulmonary TB, 2 HRST plus 6 HRE. Okay, so before going into multi-drug resistant TB regimens, first see what is multi-drug resistance. If the patient is resistant to both H and R, H means isoniazid, R means rifampicin, then they are called multi-drug resistant cases. And extensive drug resistant means HR plus fluoroquinolones and any second line injectable drug. Mainly second line injectable drugs are aminoglycosides. And if the patient is resistant to isoniazid, rifampicin, fluoroquinolone and any one of the second line drug, then they are called extensively drug resistant patient. Okay, so before going to the regimen, you should know these two terms mainly, multi-drug resistant and extensive drug resistant. Coming to regimens, remember there are 3 main regimens for MDR and XDR TB. MDR TB, 3 regimens. This is a BPAL regimen is the alternative regimen. We are not commonly using. These 2 are commonly using regimen. Shorter oral bedaquiline regimen for 9 months and longer regimen for 18 to 20 months. This longer regimen is same for extensive drug resistant TB and BPAL regimen. Coming to first shorter, all of you use this mnemonic. It's very easy. Shorter oral bedaquiline regimen for 9 months. Okay. So first 4 months intensive phase, job C. Okay, remember job C. C for I have mentioned what are all this letters stands for. C for clofazimine. H, the small h is for high dose. Okay, H means high dose isoniazid. O for this fluoroquinolone, levofloxacin. Don't tell ofloxacin. It is nothing but ofloxacin we are not using. Levofloxacin only included in TB regimen. Levofloxacin. B for bedaquiline. Z for pyrazinamide. First E for this ethionamide and E for one E for ethionamide and another E for ethambutol. Okay, so this is called job C. We are using for 4 months. Okay, intensive phase for MDR TB. Suppose at the end of 4 months, if sputum is negative, we can go for another 2 months. This because C. Okay, so this B cause C. One E and HH is removed. Okay, only ethambutyl, ethionamide and high dose isoniazid is removed only because C is used if sputum is negative. Then for another 3 months, first 2 months because C, another 2 months remove bedaquiline only cause C. Because bedaquiline we should not use for more than 6 months. There is a more chance of QT prolongation. So we should, the more toxicity will be there. So bedaquiline we should not use for more than 6 months. So intensive phase and continuation phase, first 2 months because bedaquiline is used, and next 3 months bedaquiline is removed, only cause C. So the C for clofazimine, levofloxacin, pyrazinamide and ethambutol. Okay, so totally 9 months. This is a shorter oral bedaquiline regimen. Suppose if the sputum is not negative at the end of 4 months, what is the regimen? The sputum is still positive after intensive phase. We can continue the same intensive phase for another 2 months. Okay, 6 months. Then we can continue COSI for 5 months. That is totally 11 months treatment. Okay, so same drugs, JOPSI and COSI for if the person does not convert into negative. If still positive after 4 months, we can extend the intensive phase. Okay, suppose even if you don't remember this 11 months, remember this first one, 9 months. Okay, this is very important. JOPSI, COSI and COSI. And coming to longer regimen, this is for even for XDR tuberculosis, that is extensively drug resistant, it is used. So 6 months phase for C square, B and L square. C square is nothing but clofazimine, cycloserine, CC. B for bedaquiline and L for 2L, levofloxacin and linezolid. Okay. Then another 12 months, C square, L square. We know that normally we cannot continue after 6 months. B should not continue after 6 months. So only C square, L square for another 12 months. So totally 18 months for this XDR and a longer regimen MDR TB. And next alternate is BPAL regimen. Actually, it is now only it is not included in the exact elimination program, but this regimen is there. Just remember B for bedaquiline, P for pretomanid, and L for linezolid. PA for pretomanid, L for linezolid. That is BPAL regimen. This shorter and longer regimen is very important. Okay, remember this. And coming to TB in pregnancy, same 2 HRST, 4 HRE. And you have to give pyridoxine prophylaxis. Lactating woman also same thing, but you have to, if the breastfeeding mother, if it is positive, you have to give INH prophylaxis for the infant for 6 months. And AIDS patients also same, but only thing you have to remember is instead of or, because AIDS patients, they are taking TB drugs along with HIV drugs. So rifampicin is an enzyme inducer. So replace rifabutin instead of rifampicin. Since rifampicin is an enzyme inducer, in AIDS patients, you have to replace rifampicin with rifabutin. Okay. So this is an AIDS patient. So for all the same regimen only. And chemoprophylaxis. Once they have asked chemoprophylaxis in short notes. So chemoprophylaxis also same only for a drug sensitive TB, INH 6 months. Okay, so INH for 6, remember 6H, 6 months INH. Or INH plus rifampicin for 3 months per week, 3 HP. So this is for contacts of sensitive TB. So 6H or 3 HP. 3 HP is nothing but 3 months, H for this and rifampicin, P for rifampicin. Okay. And drug resistant TB means levofloxacin plus rifampicin. Okay. So remember at least this drug sensitive TB. So who are all require chemoprophylaxis? Children with a sputum positive, any patient in a family, neonates of tubercular mother, and immunosuppressive patients, leukemia, diabetes, silicosis, or receiving any steroid, immunosuppressant drugs like steroids or any other immunosuppressants, and HIV infected sputum positive cases require infected contacts of sputum positive index cases require chemoprophylaxis. And remember this treatment regimen. And coming to last, Mycobacterium avium complex. So what are the drugs used in Mycobacterium avium complex? Mainly this therapy avium complex treatment is needed in AIDS patients because they are more prone for immunocompromised. They are immunocompromised, and this infection, opportunistic infections are commonly seen with AIDS patients. So Mycobacterium avium complex therapy is intensive phase and maintenance phase. Intensive phase 2 to 6 months. Main drugs are one macrolide, clarithrol or acithro, and ethambutol rifabutin or for intensive phase. And same maintenance phase, clarithrol or acithro, ethambutol rifabutin or any other fluoroquinone we can add for 12 months. Okay, any one drug for 12 months. So this is the regimen for Mycobacterium avium complex commonly needed in AIDS patients with CD4 count less than 100. And coming to quick revision of second line drugs which should be avoided in HIV patient. TB drug should be avoided in HIV patient, thioacetazone. Drugs which cause hypothyroidism is ethionamide. Drugs which cause cross-resistance isoniates, it is also ethionamide. Neuropsychiatric adverse effects, cycloserine. Pseudojaundice, rifabutin. Uveitis, parialgia also seen with rifabutin. Okay, that's all about tubercular drugs. So regimens very important. Please use this mnemonic to remember the regimen. Okay, MDR TB. Coming to antifungal, this is the previous year question paper they have asked 2 years back, I think. Azoles are commonly asked. So bronchial asthma patient on steroids with opportunistic infections presented with unhealed oral mucosal lesions and hardness of palate. So the patient presents with candidiasis. So what is the probable diagnosis? Candidiasis. So we can use antifungals. So antifungal azoles are repeatedly asked, and amphotericin B, terbinafine, echinocandins are commonly asked. Coming to antifungal overall mechanism, mainly this overall mechanism we can see drugs azoles mainly acts by inhibiting the ergosterol synthesis. So we know that ergosterol is needed for the normal cell wall synthesis. So this ergosterol, the final step is lanosterol is converted to ergosterol by 14-alpha demethylase. That enzyme is inhibited by azoles, all the azoles. Okay. And squalene to lanosterol by squalene epoxidase, this enzyme is inhibited by allylamines, terbinafine mainly. Okay, terbinafine group. Then drugs which directly inhibit cell wall synthesis are echinocandins, caspofungin, mainly by causing beta-1,3 glucan synthesis, inhibiting beta-1,3 glucan synthesis. This is echinocandins, caspofungin. And drugs which inhibits mitotic spindle, griseofulvin. Drugs which inhibit nucleic acid synthesis, 5-flucytosine. And drugs which form pores in the cell membrane, polyenes, amphotericin B. So remember this diagram and see this diagram and read the mechanism of action of antifungal drugs. And azoles, there are two azoles, topical and systemic, imidazoles and triazoles. Triazoles are mainly fluconazole, itraconazole, voriconazole, and imidazoles are mainly this ketoconazole and clotrimazole, miconazole, iconazole. Okay. So coming to comparison, I have made a table for azoles. Okay, so remember this. 3C for fluconazole many times asked. 3C uses for fluconazole, candidiasis, cryptococcosis, and coccidiomycosis. All the triazoles, fluconazole, itraconazole, voriconazole, posaconazole, these four main triazoles causes hepatotoxicity. Okay, and remember fluconazole use 3C, candida, crypto, coccidio. Voriconazole used in invasive aspergillosis, and adverse effect, remember V for B, visual disturbance. And posaconazole, only azole useful in mucormycosis is posaconazole. Okay, so remember this for triazoles. Come to imidazole, ketoconazole. We know main point to remember for ketoconazole is systemic. It is used nowadays rarely. Only topically we are using. It inhibits the CYP enzyme, so drug interactions are more, and severe hepatotoxicity and gynecomastia. Okay, it causes hormonal disturbances and it causes gynecomastia, CYP inhibition, so drug interactions are more. And coming to other imidazoles, clotrimazole, miconazole, topically we can commonly using these drugs. So that's all about azoles. And coming to other drugs, amphotericin B, we know that drug is mainly used for systemic mycosis, cryptococcosis, schistoplasmosis, mucormycosis, and the liposomal form of this drug is lesser toxic. Otherwise, it causes more nephrotoxicity. So we have to give normal saline infusion before giving this drug, and infusion reactions are common. So to prevent this toxicity, nowadays liposomal amphotericin B is available, but the only thing is it is more costlier. And coming to echinocandins, caspofungin, mainly useful in invasive candidiasis and aspergillosis, and it may elevate the liver enzymes and causes hepatotoxicity. And griseofulvin, useful in dermatophyte infection. Absorption is good with fatty meal. Already I have told you fatty meal, good absorption for lumefantrine in anti-malarial drug, and here also griseofulvin, fatty meal absorption is good with fatty meal. And headache, hepatotoxicity, photosensitivity are common. Terbinafine, remember TTT. Okay, terbinafine is an allylamine, inhibits squalene epoxidase. T for tinea infections it is used, and adverse effect taste disturbance. Nystatin we can use for oral thrush and oral and cutaneous candidiasis, and already I have told you the clotrimazole, miconazole. And this is, if you want, you can refer this slide, but it's very difficult to remember everything. So at least remember fluconazole, it's commonly asked, and azoles, you try to remember all the points. And coming to next, antiviral drugs. So acyclovir and oseltamivir anti-influenza drugs are commonly asked, and in a HIV, NRTA, protease inhibitors, and post-exposure prophylaxis is commonly asked in HIV. Okay. So with this, we will discuss the mechanism of action. So normally virus fuse with the host cell. First step is a fusion, then uncoating occurs, then synthesis of early protons, late proton synthesis, assembly and release. These are all the normally, sometimes this early proteins integrated with the host. Okay. So coming to main drugs, anti-influenza drugs first, they mainly inhibits the uncoating. So, okay, mainly this amantadine, trimantadine, and inhibits the uncoating step. Okay. And this neuraminidase inhibitors, also called oseltamivir, zanamivir and all, they inhibit the release. This neuraminidase inhibitors causes inhibition of release of the protons, viral protons. So these two are main mechanisms for anti-influenza drugs. Uncoating is inhibited by amantadine, trimantadine. Release is inhibited by oseltamivir, zanamivir. So coming to anti-influenza drugs, uncoating inhibitors, amantadine, trimantadine, they are mainly active against influenza A. GA complaints are common. Okay, so this is about amantadine, trimantadine. Amantadine, another uses Parkinsonism, we can use rimantadine, longer acting drug. Neuraminidase inhibitors prevents virion release. The drugs are oseltamivir, drug of choices H5N1 and H1N1. Zanamivir we can use via inhalational route, and we can use in both influenza A and B. Okay, so this once they have asked in short notes. They may ask specifically amantadine also, or neuraminidase inhibitors also, like that also they may ask, and they may ask us directly anti-influenza drugs. Once they've asked oseltamivir separately. Okay, whatever is the question, try to write the mechanism of action first. What drug it is? It is an antiviral drug specifically used in anti-influenza. Mechanism of action is it prevents the virion release. That is, they mainly act by inhibiting the neuraminidase enzyme. And uses, it is useful in influenza A and B, adverse effect neuropsychiatric disorders. In addition, you can write GI disturbances also. Coming to acyclovir, we know acyclovir, whenever acyclovir is asked, you have to write herpes simplex virus 1 and 2 and varicella zoster. Coming to mechanism of action, it is converted first into virus specific kinase into monophosphate, acyclovir monophosphate, then via host specific kinase into acyclovir triphosphate, which is the active form, which inhibits the DNA polymerase. Acyclovir, like amphotericin B, this antifungal drug, it also causes more nephrotoxicity. So maintenance of adequate hydration is very important, and very short half-life for acyclovir, so requires multiple daily dosing. And we can use this drug orally, IV or topically. Okay, that's all about acyclovir. Coming to anti-HIV drugs. So coming to anti-HIV drugs, there are various drugs available. So nucleoside reverse transcriptase, non-nucleoside reverse transcriptase, integrase inhibitors, fusion inhibitors, and chemokine receptor inhibitors and protease inhibitors are the main drugs. So fusion inhibitors, we know it mainly inhibits the attachment of the virus to the host cell by binding to this glycoproteins. Okay, so remember fusion inhibitor. So N-fu be retired. Okay, from the name itself, you can remember it's a fusion inhibitor. And chemokine inhibitor is Maravira. And this integration, because this nucleoside reverse transcriptase and non-nucleoside reverse transcriptase are drugs which inhibit the reverse transcriptase enzyme, which is involved in the synthesis of proviral RNA to proviral DNA. Okay, this proviral DNA integrates with the host DNA by the enzyme integrase. So these integrase inhibitors inhibits this step, and from that there is a early protein synthesis occurs, and maturation of this protons is inhibited by protease inhibitors. Okay, so these are all the steps involved in the HIV drugs. Coming to NRTA, nucleoside reverse transcriptase inhibitors, same like acyclovir, it is converted into triphosphate by the host kinase and inhibits the reverse transcriptase. And specific adverse effect for each drugs are zidovudine, stavudine, abacavir, didanosine, salcitabine. And so main adverse effects for Zidovudin is bone marrow suppression, Stavudin peripheral neuropathy, Abacavir hypersensitivity and MI, diadenosine pancreatitis, Zalcitabine after ulcer. All NRTIs causes lactic acidosis, hepatomegaly and steatosis. Okay. So this adverse effect mechanism common only. All the drugs converts into a triphosphate form and inhibits the reverse. From the name itself, you can write the mechanism. Okay. So inhibitor of reverse transcriptase. And active against drugs which are active against hepatitis B among NRTIs are, remember the mnemonic LET, L-E-T, LET is the mnemonic. So lamivudine, emtricitabine and tenofovir. Okay. Then comes protease inhibitors. This also is specifically asked as a short notes. From the name itself, you can write the mechanism. It inhibits protease, and inhibitors of these protease inhibitors are also inhibitors of CYP enzyme, CYP3A4. So there is a regimen called boosted PAE regimen. It is nothing but low dose ritonavir with other protease inhibitors. Ritonavir is a drug which has maximum inhibition of CYP3A4. So low dose of ritonavir we can give with other protease inhibitors to increase their plasma concentration. This is called boosted PA regimen. So whenever they ask you protease inhibitors, try to write the. So just I want to tell you that if they ask you protease inhibitors, first before going into mechanism of action, you have to write the drug names. Okay, I have not mentioned because classification income you have to remember. So I have not included the individual drugs classification in the slides. So try to write the drug names first. Okay, then write the mechanism of action and this uses and adverse effects. Okay, so inhibitors of boosted PA regimen is important for protease inhibitors, and adverse effects are metabolic abnormalities, hypercholesterolemia, diabetes, hyperlipidemia, insulin resistant and lipodystrophy. And indinavir, crystalluria is a specific adverse effect, and for atazanavir there is no metabolic adverse effects, which is commonly seen with other protease inhibitors. Okay, so these are all the differentiating points. And coming to post-exposure prophylaxis, very important. So normal first line regimen is TLD or limited. You can remember as LTD also. So nothing but tenofovir, lamivudine and dolutegravir. Remember the dose also for tenofovir and lamivudine 300 milligram, dolutegravir 50 milligram. Okay, 2 NRTI, 1 integrase inhibitor is the normal first line regimen. For post-exposure prophylaxis also same only. But post-exposure prophylaxis, you should write who need post-exposure prophylaxis, mainly healthcare workers who have exposure to HIV. And it should be started as early as possible, but within 72 hours, you should start the prophylaxis. Should be given for 28 days orally. All drugs should be given orally, and TLD is the regimen. And for infant ARV prophylaxis, we can divide the infant into low risk and high risk. For low risk infants, any one drug, nephropin or zidovudine for 6 weeks. 6 weeks is needed. For high risk children, infants, dual prophylaxis, both nephropin plus zidovudine. Okay, till 6 weeks of age is needed. If exclusive breastfeeding is given to the infant, then it can be extended to 12 weeks. So post-exposure prophylaxis, you should remember TLD regimen, 28 days within 72 hours, and for infant ARV prophylaxis. That's all about HIV. Coming to anti-amoebic drugs, anti-amoebic metronidazole is repeatedly asked, and this is the question they have asked the last previous question paper. I have seen this question. So they have given this loose stools with abdominal pain, and directly they have asked the anti-amoebic drugs. Okay, so coming to the metronidazole. So mechanism of action is, so nitro group is bioactivated by reduction and forms cytotoxic products that damages the DNA. Okay, so reduction. So by reduction, it forms a cytotoxic product which damages the DNA. That is the mechanism. For users, remember as Gupta. Gupta for metronidazole users. G for giardiasis and Gardnerella. U for ulcer. We know H. pylori regimen includes metronidazole. B for pseudomembranous colitis. I already told you pseudomembranous colitis, drug of choice is vancomycin. Alternatively, metronidazole is used. And T for trichomoniasis, A for amoebiasis and anaerobes. Okay, so Gupta is the mnemonic for metronidazole use. And one important drug interaction for metronidazole is with alcohol. That is called disulfiram-like reaction. So disulfiram mainly acts by inhibiting aldehyde dehydrogenase. So whenever if you give metronidazole with alcohol, it acts like disulfiram and inhibits the aldehyde dehydrogenase. So there will be accumulation of acetaldehyde, leads to symptoms like nausea, vomiting, headache, drowsiness, and flushing. So this is called disulfiram-like reaction. So metronidazole with alcohol, drug interaction is disulfiram-like reaction. Whenever you write metronidazole, you should write disulfiram-like reaction. So common adverse effects are nausea, metallic taste, and abdominal cramps. That's it for metronidazole. Metronidazole, sometimes they may ask us treatment of acute amoebic dysentery. Okay, twice they have asked like this also, the same question. So if they ask treatment, you have to write metronidazole in detail and also dialoxanate furovate, which is the another luminal amebicide, which is used to eliminate the cyst, to eliminate the carrier state. Okay, so both the drugs you have to explain if they ask you treatment of acute amoebic dysentery, and you have to write what is just a luminal amebicide used to eradicate cyst. Coming to next, anti-helminthic drugs. So anti-helminthic drugs actually, ivermectin is many times, and scabies treatment is many times asked, and filariasis, drugs used in filariasis. So ivermectin first, actually this is the overall mechanism for all the anti-helminthic I have included with this image. So microtubule inhibitors are mainly albendazole, mebendazole, triclabendazole. Drugs which cause spastic paralysis are praziquantel by causing calcium influx, levomazole causing spastic paralysis by stimulating the nicotinic muscle receptor, and pyrantel pomabate causes depolarization. So all these drugs, PLP causes spastic paralysis, and flaccid paralysis mainly by piperazine, which opens GABA-mediated chloride channel, and ivermectin, which opens glutamate chloride channel and causes flaccid paralysis. Try to use this slide for remembering the mechanism. See, suppose if they ask you albendazole also, you can write this is a microtubule inhibitor and write the uses. Okay. So coming to ivermectin, mainly it is used for scabies and pediculosis in addition to filariasis, onchocerciasis, and strongyloidosis, and potentiates the GABAergic transmission in the worm and causes flaccid paralysis. Okay, and diethyl carbamazine, mainly it acts by altering the microfiliary membrane and increases the phagocytosis. It is the drug of choice in filariasis, lova and tropical eosinophilia. Okay. And overall uses of this anti-helminthics. Remember, for all cestode and flukes, drug of choice is praziquantel. Okay, so cestodes, fluke, tinea, mainly tinea infection, tinea, solium, cyanide, everything, drug of choice is praziquantel. Except hydatid cyst and neurocysticercosis, albendazole is there. This is the important MCQ. Drug of choice in neurocysticercosis is albendazole. Hydatid cyst is albendazole. And all nematodes, Ascaris ankylostoma, drug of choice is albendazole, mebendazole. And strongyloidosis, onchocerca, I have told you, drug of choice is ivermectin. Filariasis, diethyl carbamazine. And guinea-worm disease, metronidazole. Fasciole hepatica, triclabendazole is the drug. So remember, ivermectin is commonly asked. Coming to anti-leprosy, they have asked clofazimine and leprorelin, dapsone, and a regimen. So dapsone, it is leprostatic drug. Mainly dapsone comes in a sulfonamide. So it inhibits the folic acid synthase enzyme and inhibits the folic acid synthesis. ADR is hemolytic anemia, hepatitis A granulocytosis. Leprosy we are using. In addition, we can use along in chloroquine-resistant malaria, toxoplasmosis, and pneumocystis jirovecii infection. Clofazimine, it is a dye. It is leprostatic and anti-inflammatory action. Mainly, it interferes with the template function of DNA. It is included in the multi-drug therapy for regimens in leprosy. It is useful in lepra reaction, and it is useful in extensive drug-resistant TB also. Adverse effect is discoloration. That is the main side effect seen with clofazimine, and nausea, anorexia, GIT adverse effects are seen. And coming to regimen, treatment of lepra, many times this treatment of lepra reaction is asked. Type 1 and type 2, we have divided the lepra reaction into. So this type 1 reaction occurs in LL type of leprosy. This causes orthus mediated, orthus type. Treatment is clofazimine, steroids, and thalidomide are useful in type 1 reaction. Type 2 mainly occurs in TT and BL type of leprosy, and it is due to delayed hypersensitivity. Treatment mainly contains clofazimine and steroids. Okay, so thalidomide is useful in type 1. And multi-drug regimen therapy is rifampicin, dapsone, clofazimine. Duration for paucibacillary leprosy, 6 months duration. And multibacillary leprosy, these 3 drugs for 12 months. And dosage, rifampicin 600 mg once a month, dapsone 100 mg daily, and clofazimine only included for multibacillary regimen. Multibacillary regimen, 300 mg once a month plus 50 mg daily. Okay, that's all about the third part. So third part is very vast and it is very important. You may expect any essay. Okay, so TB, leprosy, malaria, and fungal also many times in essay they have asked. Okay, and viral many short notes they have asked, and amoeba also once they asked in the essay metronidazole. Okay, okay, that's all about third part of questions. Coming to fourth part, I'll try to finish in another 10 minutes more. So last part, actually you can't expect essays, but once they've asked anti-cancer, once they have asked anti-metabolites in essay. Okay, other things are mostly, but minimum 2 short notes are commonly they are asking from cancer. Okay, nowadays they are concentrating more on anti-cancer drugs. So please don't omit anti-cancer drugs. They are repeatedly, they are asking many short notes you may expect. And once they have asked essay also anti-metabolites. Okay, so alkylating agents, methotrexate, vinca, platinum compounds, cyclophosphamide, taxanes are commonly asked. So coming to anti-metabolites, once they have asked in essay, it acts in S phase. All the groups are mainly folic acid antagonist. Methotrexate is comes under anti-metabolite, purine antagonist, and pyrimidine antagonist. Methotrexate, even many times they were asked in short notes also, they acts by inhibiting dihydrofolate reductase. Mnemonic is cancer. Cancer is the mnemonic for uses of methotrexate. Choriocarcinoma, acute leukemia, ALL, AML, non-Hodgkin's lymphoma, Crohn's disease, ectopic pregnancy, rheumatoid arthritis, all are uses of methotrexate. Adverse effect is bone marrow suppression, megaloblastic anemia are main adverse effects seen with. And treatment for methotrexate toxicity is very important. Leucovorin, it is nothing but folinic acid, or also called as citrovorum factor. And it has N5, N10 tetra formyl folic acid. That you have to remember, leucovorin, N5, N10 tetrahydroformyl folic acid. Okay, so this is the toxicity treatment, citrovorum factor. Coming to purine antagonist, I have made it for purine and pyrimidine. I have made it as a table. 6 mercaptopurine, 6 thioguanine, azathioprine. So try to remember all the drugs causes, even if you don't know, because all the drugs causes myelosuppression and hepatotoxicity mostly. So at least myelosuppression you can write for all the drugs, anti-cancer drugs as a adverse effect, and a specific which purine antagonist mean they inhibit the purine synthesis. Even if you don't know the exact step, right, it inhibits the purine synthesis. Write the drug names and use mainly in the hematological malignancies, ALL, AML, leukemia. Okay, purine antagonist. Pyrimidine antagonist mainly used in this solid cancers, 5-fluorouracil in colorectal breast cancer, capecitabine in breast, gemcitabine in, this is an important MCQ. Gemcitabine useful in pancreatic CA, and all these drugs inhibit the pyrimidine synthesis. And hand foot syndrome, important adverse effect for capecitabine. Okay. Next, alkylating agents, main mechanism is forms covalent bonds with DNA, leads to cross-linking and inhibit the DNA strand, causes breaking of DNA strands. This is the mnemonic. Remember the drug names, please. Due to time constraint, I will share the PPT. You can, anyhow, you have to memorize this. Okay. And temozolomide, glioma, melphalan, MM. Remember M for M, multiple myeloma, it is used. Mitomycin for superficial bladder cancer. And adverse effects for specific drugs, cyclophosphamide, hemorrhagic cystitis. Treatment for this hemorrhagic cystitis is MESNA. Okay, remember that. They may ask you in short notes. Busulfan, pulmonary fibrosis, nitrosourea, NN, neutropenia, procarbazine, disulfuramic reaction. These are some adverse effects. So it is already asked in short notes. M phase specific, they may ask us short notes individually, vincalcolides, taxanes, individually also they may ask, or yes, M phase specific drugs like that also they may. If they ask us M phase, once they've asked like this, M phase specific drugs, if they ask, you have to write about in detail about vinca, taxane and epothilones. At least write vinca and taxanes. These two are very important. And vinpistine, vinpastine, vinorelbine inhibit tubulin polymerization, normally useful in metastatic testicular cancers and leukemia, hematological malignancies. And these are adverse effects. Blast, so BB, bone marrow suppression, vincristine neuropathy, neurotoxicity. Taxanes, paclitaxel, docetaxel, stabilize microtubules, prevent depolymerization, useful in solid CA, mainly ovarian breast CA, peripheral neuropathy and hypersensitivity are common. Platinum compounds also important short notes, cisplatin, carboplatin, oxaliplatin. They cause DNA cross-linking, same mechanism for all the drugs. Indications mainly in solid cancers. oxaliplatin for colorectal, carboplatin for ovarian and lung, and cisplatin for lung, testicular, ovarian. Toxicity, cisplatin nephrotoxicity, and which is the drug which causes more emetogenic cisplatin. So carboplatin myelosuppression, oxaliplatin neurotoxicity. And hormonal agents, give a look. Suppose if they ask, you have to write individually. It is you are covered all these drugs in hormones. So just have a look. Hormonal agents in cancer. Once they have asked in short notes. And imatinib, it is a tyrosine kinase inhibitors used in CML, and proteasome. Once they asked in short notes, it is nothing but bortezomib drugs. Bortezomib useful in multiple myeloma. That's all about anti-cancer. Immunosuppressants, you know, cyclosporin is main, and tacrolimus and mTOR inhibitors. Cyclosporin, it is a calcineurin inhibitor. It is useful in graft rejection, treatment of graft rejection reaction, and all the transplant patients we can use. And second line drug in rheumatoid arthritis, bronchial asthma, uveitis, irritable bowel syndrome, other uses also there. And nephrotoxicity is the major limitation, and hyperkalemia, diabetes, hyperglycemia, gum hyperplasia, hypertension, all are adverse effects of calcineurin. And tacrolimus also, it is also a calcineurin inhibitor, but actually it binds to different protein called FKBP, that is FK506 binding protein, and it is a macrolide tacrolimus. It is also, it is high potent than compared to cyclosporin. Okay. And dose limiting toxicity for this also renal toxicity, but compared to cyclosporin, it is less. Sirolimus, it is called mTOR inhibitor, which is nothing but mammalian target. Mainly it is used in graft rejection, and also prevents the restenosis in bypass patients. Okay, coronary bypass graft patients, it prevents the restenosis. Adverse effect is thrombocytopenia. So that's all about cyclosporin, tacrolimus, and sirolimus. Mycophenolate mofetil, 2 times they were asked this short notes. It is an inhibitor of IMP, that is inosine monophosphate dehydrogenase. So inhibitor of urine synthesis. It is an immunosuppressant. We can use in patients refractory to steroids, and the main adverse effect myelosuppression. That's all about the anti-cancer and immunosuppressants. Coming to skin and miscellaneous, skin and chelating, please read psoriasis and acne. Okay, I have made 2 tables for psoriasis and acne. So remember this for acne, brain, BRAM, instead of brain or brain, benzyl peroxide, retinoids, antibiotics, and isotretinoin, and hormonal drugs, regulators of hormones. Okay, so retinoids, all the drugs mainly they are comedolytic and keratolytic. Okay, and antibiotics we can write the exact mechanism. Azelaic acid is safe in pregnancy, and we know retinoids are not topically we can use, but orally retinoids are teratogenic. Okay, otherwise these are all the drugs used in acne. Psoriasis, topical agents and systemic agents are there. Topically we can use steroids, calcipotriol, tazarotene, coal tar, and tacrolimus and salicylic acid. And see the mechanisms. Okay, most of the drugs are immunosuppressive drugs, keratolytics, and they mainly regulate the keratinocyte proliferation, all the drugs. And we can use in all the types of psoriasis. And systemic drugs are all the immunosuppressants, mainly methotrexate, cyclosporin, and TNF alpha inhibitors also used in psoriasis. Remember at least 3 to 5 drugs. If they mainly they may ask in short notes only. Remember, try to remember at least 5 drugs. And keratolytic agents, these are all the salicylic acid, urea, glycolic acid, benzyl peroxide, sulfur, all are keratolytic agents. Mainly these drugs causes this hyperpigmentation or as an adverse effect. Okay, irritation also they may cause. And this keratolytics mainly used in burning sensation, irritations we can use. So coming to chelating agents. Chelating agents, mainly these are repeatedly asked. Iron chelators, D-penicillamine, dimercaprol. Remember another name for dimercaprol like British antilucide. And all the arsenic, mercury, gold, and lead poisoning dimercaprol is used. D-penicillamine is used in Wilson's disease, lead mercury, and rheumatoid arthritis. We can use, and this desferoxamine we can use in acute iron poisoning, chronic iron overload. And the route of administration is intramuscular, subcutaneous, and D-penicillamine is oral. And mechanism binds metals. We know chelating agents normally it binds with metals, form a complex, and it prevents the action of that specific drug. Okay. Same thing for D-penicillamine. This forms ferrioxamine complex, dysferrioxamine. And side effects: hypertension, tachycardia, and pain at injection site, dysferroxamine flushing reactions, and J upset. And it is difficult to remember specific adverse effect for all these agents. At least remember the mechanism and drug name. And so once they have asked like this, treatment of iron toxicity. So you have to write all the procedure. So first is gastric lavage, supportive care, chelation. Mainly first line is dysferroxamine. This drug of choice for acute iron poisoning is dysferrioxamine. Deferiprone used for chronic iron overload. Okay. And indications for chelation, mainly more than 500 microgram only we use normally the chelating agents. Okay. That's all about treatment of iron toxicity. Okay, that's all about chelating agents. Actually, I have rushed this skin and chelating because it's very difficult to read each line by line in so concentrate minimum 5 drugs for acne and psoriasis and characterolytic agents, few characterolytic agents and chelating agents. These are repeated questions. Okay, that's all about chelating agents. Any doubts, ma? Yes, any doubts? And these are other miscellaneous questions asked, ma. Antioxidant, vitamins, zinc, sometimes antiseptics also. These are all you can write on your own. This sunscreens. Okay, these are a few questions rarely they have asked. Okay, so see this also. Any doubts, ma? Sorry, I have rushed this immunosuppressants. After anti-cancer, I have rushed, but I have shared this PPT. I will share this PPT. Okay, refer the PPT and read. It will be useful for you because I have made many mnemonics and I have made many tables so that you can read easily. And please concentrate. Don't leave this anti-cancer drugs. Many students find it difficult to read this anti-cancer drugs, but minimum 2 short notes are commonly they are asking from this immunosuppressants and anti-cancer. Okay, so at least the questions I have put in this PPT try to cover, and mnemonics, replace the mnemonics I have used in the PPT, and remember the drug names. Hope I think the session is useful for you, was useful for you. So any questions you can ask, any answers for specific questions in the previous paper if you want to know. Yes. Any doubts, ma? Any doubts? Okay, thank you. So all the best for your exams. I have first I have told you the format for answer no, so follow that and try to answer the questions. Don't omit any questions. Don't leave any questions. Try to attend all the questions. Write the drug name, mechanism, uses, and adverse effect. These 4 headings are much important. If you know, you can add the contraindications and interactions. Okay. Okay. Thank you. Any doubts, ma? I'll share the PPT. Sure, I will share the PPT.
Ma'am, so doubt, ma'am.
Yes. Yes, ma. Yes.
So if you remember the exact dose of the drug, so you can write.
No need. No need. My exact dose, it's very difficult. So no need. The dosage is not very, no need to remember the dosages. And also no need to read the individual drugs. But because if, for example, captopril, enalapril, lisinopril, many usually students ask, we have to read all the points for each individual drug. It's very difficult. Okay. So read the prototype drug actions. If they ask any specific drug also, you can write the, because mechanism is common for that group. Okay. So write the common mechanism and write the common user's adverse effect. Okay, no need. If you know any specific characteristic point of that particular drug, you can add. Otherwise, you can write the common mechanism, common uses, and common adverse effects. That is for UG level, that is enough. Okay, so and also one of you asked this whether chemical classification is important or based on whichever is comfortable, because many students usually feel like it's difficult to remember the chemical classification. So better based on the mechanism of the action also you can write, no issues. Even if you don't know the mechanism, at least try to write the drug names. That is enough. For anti-malaria and all, chemical classification, if you forget chemical name, at least if you remember the drug name, write the drug name. No need to write that chemical name. Okay. If you remember, it is good. Otherwise, don't get panic. Try to write the drug names alone. No issues. For UG level, we will expect that only. And main adverse effect only we will expect. Okay. So even if you don't know the adverse effect, try to write adverse effects common, because all the drugs produces GI adverse effect. Try to write that and at least highlight the characteristic adverse effect. That is enough. For anti-epileptic, based on ion channel classification is enough. One of you asked. Any other doubts, ma? Yes, any other doubts?
Hello, ma'am.
Yes, ma. Yes.
Ma'am, if the meeting is ended, we can end the meeting with the mantra, ma'am. Shanti mantra, ma'am.
Okay. So, okay, ma. If you have no doubts, no issues. If you have any doubt, ask in group also. We will answer. No problem. I will share the PPT. Okay. So all the best once again for your exams. Thank you.
Shanti mantra. Sarve bhavantu sukhinah, sarve santu niramayah, सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत् ॐ शान्ति शान्ति शान्तिः. Thank you.
Thank you.
Thank you.